Bismillahirrahmanirrahim.
So let's start with a presentation for today, and it's about the diagnostic approach to peripheral neuromuscular disorders. And I know as a neurologist and even during residency, we all do central neurology or examination much more frequently. And most of the residents, and even I can tell you, even at the attending level, you kind of feel deficient, or sometimes you feel that what needs to be done, what should be the way forward. So I remember doing kind of checklist phenomena for my colleagues as well. And then later on doing neuromuscular medicine as a fellowship really helped me refine my own approach. But it's like how you kind of approach a patient, understanding it's a peripheral neuromuscular condition. And to get into the idea of neuromuscular disorders, we first need to understand a little bit of anatomy. So the usual approach is kind of the same for any medical disorder we approach to. So history examination, differential diagnosis, and then we refine our differential diagnosis or narrow it down by doing the ancillary testing. Also, we do ancillary testing to confirm what we are thinking. The basic question remains the same. In neurology, as PGY2s, you must have heard this many times: where is the lesion and what is the lesion? So where we're gonna assess with on the basis of the history, examination, and then we do some ancillary testing to confirm. But beside that, we can do some blood test imaging to know what is the lesion. Basic anatomy with the neuroaxis motor unit. So it starts with the anterior horn cells, then we know there's an axon, and then there are axon terminal. Axon terminal ends up at axon buttons, which kind of makes the what we call in neurophysiology as motor end plate, or other word is neuromuscular junction, and then comes the muscle. So it seems simple by this image or photograph, but to be very true, there are people who are just specialized in nerve disorders. There are people who are specialized just in muscle disorders. So there is a whole lot of depth to neurology. So then when we talk about motor unit and the sensory units, for the sensory, it has to be dorsal root, and then dorsal root ganglion, and then we have the nerve, which is having both motor and sensory components. For the motor division or the motor from the anterior horn cells, there are multiple rootlets, which is anterior rami, posterior rami. They kind of clump together and give you nerves, and those nerves gives off different kind of bundle of branches. So when we talk about, there are different plexuses, especially the brachial plexus and the lumbosacral plexus. And there's a whole lot of depth and localization. We can do that sometime later on during our neuromuscular EMG lecture, when we talk about the brachial plexus or lumbosacral plexus. But usually I remember by the mnemonic RTC, so roots, trunks, and cords, followed by nerves. But that was just part of it. Next comes the autonomic innervation. I just put down that image for the heart, but there is adrenal medulla, then there is other scattered islets of where we do have our autonomic nervous system clustered. And that is a separate part of what we call peripheral neuromuscular disorders. That can be done separately as well. So we're going to talk mainly how to approach peripheral neuromuscular disorders, how to differentiate them from the central nervous system, and some people may be very interested in stroke, so I can ask a few questions from them. Then there is, we have to differentiate, is it a focal involvement or a diffuse involvement? When we call focal or diffuse, that will give us the idea what particular part of the neuroaxis or the motor unit or sensory unit is involved. And then when we get the history and examination, we also try to see, is it the involvement of the motor part or the sensory part, or both involved? I intentionally didn't put down autonomic because it will make more confused for you guys. So when we talk about the peripheral neuromuscular disorders, I'll say two questions are very important. So as you start getting in the detail, the most important thing what you come across is either the peripheral pain or the weakness. So when we talk about the peripheral pain, usually when I talk to my patients, pain could be for many other reasons. You can always talk to me about that, like ischemic pain or cell death pain, whatever. But the way I try to differentiate for my patients in the neuromuscular clinic, I tend to tell them that usually the origin of peripheral pain is either nerve or muscle or joint. And we have to differentiate between the three to understand what structure is involved. That seems easy, but it's not, because usually it's a combination. So it could be a nerve pain with a muscle pain, it's a muscle pain with a joint pain, or it's a combination of all three, which makes it even more fun. When it comes to the weakness, which I already said that there are two most important questions in the neuromuscular clinic. One is about pain, and the second is about weakness. So we have to differentiate as a central weakness or a peripheral weakness. I'm not getting into the details for the central, but for the peripheral, then we have to see what part is involved. So the location is like proximal or distal. Is there a bulbar involvement? Is there an ocular involvement? Or there is an axial involvement? Now, coming to the history, as I said, the two most important questions is weakness and the pain. Now, coming to history, we always, like in stroke patients, we want to know the age, but in peripheral neuromuscular conditions, age is very important because it will change your differential diagnosis pretty much. Next thing is the acuity of the issue. So if it is less than 2 weeks, it's acute. 2 weeks to 8 weeks is subacute. If it is more than 8 weeks, is chronic. But this kind of demarcation is just arbitrary. So it gives you some clue, but not a whole lot of idea about the acuity of the issue. Then comes the trigger or the inciting factor. That is very important, especially when it comes to channelopathies. You want to ask these patients, is it worsened by cold, heat, or temperature variation, with the food, with exercise, like metabolic myopathies, and all those factors could be very helpful in these patients to have some idea. Again, all of these questions give you the idea. And I usually call it pieces of the puzzle. The people who have worked with me, they're going to hear these things again and again. I have my own kind of slangs to share, and all those different proverbs or whatever. So, but it's just like putting all those pieces of the puzzle to have a clear understanding of what's going on. And believe me or not, it helps you in narrowing down the differential. Still, you have to work on a couple of things when it comes to investigations. And I can assure you, with time, you really come down to 2 or 3 when you are at the final end of your differential diagnosis and investigations. Next comes the progression. So when we talk about progression, so there is progression of the symptoms, but more importantly, what we need to ask which patient, because many times, especially genetic neuromuscular disorders, they develop so slowly, or if somebody has neuropathy and is slowly progressive, they may not notice a lot of symptoms for a couple of months to years. So we usually ask our patients what their issues were, or did they notice any issues growing up, like from the birth onwards, like was there a delayed cry? Did they start walking at the right age? And I can tell you, I presented a patient before who started walking at the age of 2 years, and she was a girl, the CMT patient I presented last time, and her sibling brother started walking at the age of 12 months. And generally, girls start walking earlier compared to boys. If you work on the pediatric side, you will know that part. But that was important. That patient turned out to have CMT later on. So, like tripping, having sprained ankles, all those information is very, very helpful in these patients to understand the progression of the disease or the development of the milestones. Next comes the region or structure involvement. When we talk about the region, is it like upper extremity, upper and lower extremities? Okay, what part involved first? And when we try to get that information, it's like what patient gonna tell us, oh, I feel my arm is weak, but there is more than one ways to address it. And I'll talk about that because that is, I think, is the more fun part of neuromuscular. And those are the questions that we ask in clinic, which other subdivisions in neurology don't ask, or they don't ask that way, I'll say. Then we have to understand if a patient is having weakness, what's the pattern of weakness? Is it fixed? Is it episodic, like myasthenia gravis, Lambert-Eaton myasthenic syndrome, or channelopathies? Those are all episodic weaknesses. But it could be fixed, and then there is a progression pattern to that. Okay, I was talking about the fun part of neuromuscular clinic, and that is about the activities of daily living. So the patient gonna come to you, and they're gonna like okay, we feel weak, so how much weak you are, the anesthetic cannot tell you. It's like 3/5. So you're going to ask them what's happening over the period of time. Is it like, do you do 1 flight of stairs now, and previously you were able to do 2 flights? So you have to document that, because that is important, and you are putting some quantitative measure in your patient notes. Or you're going to ask them, okay, you are able to pick something from the shelf. You're going to see that in my notes whenever you're going to come across. Those notes stay in the system. So whatever good or bad you do, it stays there. So, and you guys like, are you able to pick things from the shelf? How long that's been going on? And is it like signing a paper is difficult, or maneuvering the buttons is harder, or zipper is harder, or what's actually was the initial thing, and then it's get to the next part. Now I'm not able to use a fork. I cannot eat. I cannot dress myself. And like when we see patients in the ALS clinic, they don't use shirts without buttons. They just pull it on because they cannot tie the buttons or have the laces to tie up. Similarly, shoes, same way. They kind of try to have slip-ons rather than those with laces. So same goes with the lower extremities. So there's a difference, and I'll give you some of my 2 cents about it as we talk about the examination. So, but those are the questions that will give you the idea. Was it primarily a proximal weakness or a distal weakness? And remember, this is more important because many times when I see patients in my neuromuscular clinic, they are having advanced neuromuscular disease, so everything is mixed up. So they have more diffuse weakness. Then it becomes harder to really tell, was it a proximal or distal in the start. So the start is always very important. And I always recommend, if you feel this patient is having some neuromuscular condition, do refer to neuromuscular clinic early on rather than waiting on the patient for investigation and whatnot. Then comes the comorbid medical conditions. And when we talk about the comorbid medical conditions, it happens many times, especially in any medical practice, that small things kind of gets together. If a patient is having renal failure and then having a little bit of diabetes, now renal failure gives you neuropathy, and also diabetes gives you neuropathy, and both together gonna give you much severe form of neuropathy compared to a regular, and the progression may be faster. So understanding all these comorbid medical conditions is very important. I recently had like 2 patients who came in for same one question. Patient had breast cancer, got chemotherapy, radiotherapy, besides surgery, and now a couple of years later, patient is having pain and weakness in the arm. So what's going on? So is it like a recurrence of the tumor? They don't see a recurrence of the tumor. So, you know, when many times when patient come into the clinic, they have all sort of workup for you, and they just like, okay, now what you think would be the next thing to do? And then you have to kind of put your Sherlock Holmes cap on and work on those cases. That's what I love to do. Now, when it comes to examination, other than history, so there's a general examination, and then there is a neuro examination. General examination, we want to make sure there is any autoimmune condition, like thinking about polymyositis, dermatomyositis, which can give you a clue, patient having some rheumatoid arthritis features. They may have that in the history as well, but it is important to know or understand the severity of the disease. If a patient is having really bad joint disease, you expect kind of the same going on with the peripheral nervous system as well. Then you're going to do your neuro examination and neuromuscular examination, and there are many ways to go around that. So next, you have to look at the joint deformity or skeletal abnormalities. Now, when I say joint or skeletal, you have to look for scoliosis, any abnormal like Trendelenburg sign, like pelvic dislocation, whatever, those signs. And I can tell you, in today's busy practice, many times we try to avoid it. As a neuromuscular specialist, you have to make sure that you spend time with your patients and be comfortable with the examination. Then comes the involuntary movements. So you can see cramps, you can see myotonia, you can see fasciculations. So all sort of involuntary movements you can see in your patients. But you have to be careful, and you should know where to look for. So palpation, again, kind of gives you the idea about the tone, especially for the upper motor neuron pathology. It can also give you some idea about the lower motor neuron pathology. Also, it can give you an idea about the movement. So if there is a myokymia, if there is a fasciculations, you're not sure, then it can kind of give you some idea. Percussion, myotonic dystrophy. So that's where we do it, percussion, tongue percussion, and our tenor eminence percussion. But We also do for fasciculations and to elicit involuntary movements. So that's another reason we do percussion as well. It's not, I mean, you can do it with the hammer, otherwise you can just tap it and see if there is abnormal fasciculations or movements. That can give you the idea. Deep tendon reflexes, we'll talk about that more. I don't know what's going on over there. So it's like, what's all these minus, plus, whatever, right? So I told you if you don't see any movement, any flicker of movement is 0, but then you have to feel it or palpate the muscle and ask the patient to do a movement or try to do a movement. If you still feel it, you're going to call it 1. Okay? Yeah. Then we do know if it's anti-gravity is 3, but if it's along the plane, then you have to see is it partial range of movement or full range of movement. So if there's a partial range of movement, it's minus. If a full range of movement, is 2. If it is a good plus or like good range of movement, anti-gravity, but some getting into the next. So this is a little confusing, +2 and -3. But the rest is a little more easier to be very true. So I tend to write down 3 and 4 as plus minus, 2 rarely. But that is by the range of movement you can guess it, and it can give you some idea. So again, anti-gravity is 3. If you're able to hold against resistance, is it mild or moderate to how good, strong? Then based on that, you're going to scale it -4 plus. When you guys going to work with me in clinic, I'll do and show you more, but it's more of a perception of the examiner. Again, it's somewhat examiner dependent as well, but at the same time, it does help, like a patient who was -4 today and next time he's -3, that's the difference. So that's why, because this is not a very sensitive scale, so they do use specific devices in neuromuscular clinic like dynamometer to check for the strength of the patient. Now comes the sensation testing, my field, pinprick, cold, vibration, joint position sense, and touch. So yeah, so initially we check for the pinprick. If that doesn't work, you can do the cold sensation testing, okay, if you don't have something to prick on the patient, or the skin is so fragile that you think you can cause more damage. Otherwise, similarly, you check for the vibration, and then if you don't have tuning fork, then you can check for the joint position sense. Or there is some differential as well. So joint position sense may be involved in some disorders compared to vibration, and vibration more involved compared to joint position sense. And similarly, there is a differential between the pinprick and cold as well. So there is a whole lot of fine points to that. Touch is kind of covered anywhere, so as I said, you can just check it, but usually I don't recommend it. On the follow-up exam, I rarely do it if that is not the primary abnormality in that patient. Sensory ataxia, tandem gait, and Romberg sign. When you are standing, okay, your internal ear canals are giving you the idea about the balance. Your joint position sense is giving you the idea about the terrain or the floor. Okay, your eyes are giving you the idea that it's not bumpy here and there. So that's also giving you input, even if you take a step and there is a stone or something, right? So that's an added like precautionary thing. Next comes the tandem gait. It's kind of similar phenomena. If a patient is having a baseline, not able to stand even with the legs open up, you don't need to do the tandem gait. So it's already ataxic, and it's probably cerebellar. But as I said, the fun part is when you have to differentiate how much is cerebellar and how much is spinal cord because of the dorsal column. Neurology is all about how you can tease out the abnormality. So remember, that's the fun part. And that shows how good you are. Okay? It's very easy to get an MRI. It's very easy to get the blood test done. Okay? But that's why many times many of us are lost because we haven't done a good history and examination. Okay? And that always gives you some idea. I always say that we are deficient, even I'm deficient in knowledge. We need to keep ourselves updated. Okay? So that is about the tandem assessment and Romberg signs. So localization, Langerhans cells, dorsal root ganglion, radiculopathy, plexopathy. It could be at the level of the nerves, and then we have to see is there a single nerve or multiple nerves are involved, neuromuscular junction, muscle, and fun part, combination of upper and lower motor neuron lesions. So that is where is the lesion, okay? But now look at this. This is axial involvement. We were talking about respiratory muscle involvement, right? So it can happen in ALS, which is an anterior horn cell disorder. It can happen in myasthenia gravis, which is a neuromuscular junction disorder. It can happen with phrenic nerve injury because the patient had some central line which kind of went somewhere. Okay, or it could be acid maltase deficiency, which is a genetic disorder of muscles. You got my point? So it's the same manifestation of the respiratory weakness or respiratory problem, but look at the variability of pathology. So that example is just to show the variability. So you not only check the primary problem, but what's around it is very important. So this is on continuum as well. So I just want you guys to kind of quickly skim through it. They tried to put down a framework, but believe me, there was a paper where they put down 9 different patterns of involvement when it comes to peripheral nervous system. Okay, so proximal and distal, and then distal. This is very easy, by the way. And then they try to put a sensory-motor, motor, and sensory. Okay, so if it's in the upper left corner, it's symmetric. It's the lower right corner, it's asymmetric involvement. And believe me, that's the fun part. As I said, initially, if you do the history and examination in the early on, it's easier. Later on, all these things become more mixed up, and it becomes very hard to differentiate. So if a patient comes in with a burnout myopathy, you cannot even differentiate a burnout neuropathy from that patient because nerves are out and the muscles are out as well. So now coming to this, if there is a proximal central sensory-motor involvement, it's diabetic lumbosacral plexopathy. So diabetic amyotrophy happens in the first 5 years of the disease. It doesn't matter patient's diabetes is controlled or not, with the remarkable weight loss in the thigh muscles, and it's symmetric. And then if there is a proximal motor symmetric involvement, there is a spinobulbar muscular atrophy, which is Kennedy's disease, brachial amyotrophy, that's what we were talking about, diplegia. Remember, there's a common pattern and then there are uncommon patterns. So whenever there's a proximal weakness, always think about the muscle first. If there is a distal, think about the nerve first. When there is a proximal and distal, then think about the AIDP and CIDP. Okay? And if it's asymmetric, then always think about, and if there is a sensory motor involvement, then first thing is motor neuritis multiplex or autoimmune disorders. But then there could be CIDP variant, or there could be hereditary neuropathy with pressure palsy. So again, all these clues are in the history and examination rather than the investigations, because if you don't do a dedicated history and exam, you will be totally lost in the investigation section. Then if there is a pure motor involvement and it's proximal and distal, again SMA, as I said, advanced disease, it could be progressive muscular atrophy, infectious or paraneoplastic MND, haven't seen a single patient with that. So myopathy like facial scapulohumeral muscular dystrophy, neuromuscular junction disorder, and pure motor CIDP, which is distal, but it could be proximal and distal as well. Asymmetric ALS, okay, MMN, and some myopathies like inclusion body myositis. So inclusion body myositis is what is upper extremity distal, lower extremity proximal. That's another pattern, like lower extremity distal, upper extremity proximal. So as I said, there are 9 different patterns to that. So then comes symmetric, sensory, proximal and distal involvement. Then there is a dorsal column dysfunction, or there could be chronic inflammatory sensory polyradicular neuropathy or neuronopathy. And then there is if it's asymmetric, then there is sensory neuronopathy. Distal sensory motor, if it is symmetric, then it is distal symmetric polyneuropathy, which is the most common variety, or CMT or DADS. We already talked about the DADS has been changed now, right? Distal sensory motor polyneuropathy, simple. Okay, so and then symmetric distal motor is distal hereditary motor neuropathy. So that's kind of an overlap where it becomes very confusing between the motor and the motor neuropathy with the predominantly motor axon involvement. Okay, so it could be our SMA type, or it could be our hereditary motor neuropathies and distal myopathies. Okay. So symmetric distal sensory is a distal symmetric polyneuropathy, which is the most common variety again for. And when we talk about that, there's a differential for each one of those. We can talk about that in investigation. I'm going to talk about it a little bit. So proximal predominant weakness could be motor neuron disease, which is spinal muscular atrophy is one variant of that, spinal bulbar muscular atrophy. When it comes to nerves, the CIDP, acute intermittent porphyria, which presents acutely, it's episodic, it's proximal. Tic paralysis, again, primarily proximal neuropathy is not common, so this has to be the differential when you're thinking, okay? Neuromuscular junction is just like muscle is proximal. Muscles, most of the muscle problems are proximal. So most myopathies, channelopathies are having proximal weakness. Next slide. Distal predominant weakness. So motor neuron is there. ALS, distal spinal muscular atrophy, which is hereditary motor neuropathy, as I said, is kind of overlaps with the motor neuron disease. Neuropathies, most of the neuropathies are distal predominant, and we tend not to get any reason for that. It's an axonal variant of it. Neuromuscular junction, then there could be rare presentation of myasthenia gravis, okay? Muscles, inclusion body myositis, myotonic dystrophy is distal. These are the old names, but these are, I have seen Miyoshi, I have seen Nonaka. We presented Nonaka in one of the conferences as well. So we Lender, Ode, Marquisburg, so there are a couple of others. Next. Combined proximal and distal. Motor neuron disease later stage, as just we heard from one of, yeah. And then nerves, GBS, CIDP, and then neuromuscular junction, botulism is one, but there has to be what? Then asymmetric weakness, so there could be motor neuron, early stage of ALS, nerves, multifocal motor neuropathy, one, and it's upper extremity predominant, vasculitic neuropathy, entrapment or traumatic neuropathy, radiculopathies, plexopathies are asymmetric. Neuromuscular junction disorder, oculoburbal, kind of. So I saw a patient, just I can share with you guys. So it's like 1% of myasthenia gravis patient can present with initial diaphragmatic involvement, and I saw that patient. And he was maintained on rituximab. Okay, so muscle inclusion body myositis, facioscapulohumeral muscular dystrophy, oculoburbal involvement. So motor neurons, again, ALS, spinal muscular atrophy, spinal bulbar atrophy. So if you look through it, ALS is there, motor neuron disease is there everywhere, right? In all the patterns, symmetric, asymmetric, proximal, distal, whatever. Nerves, GBS, Miller-Fisher is a common one, okay? So compressive, infiltrative, or inflammatory. And then neuromuscular, myasthenia gravis, congenital myasthenic syndrome, botulism, bulbar, we already talked about that, bulbar involvement more common, okay? Muscles, chronic progressive external ophthalmoplegia, Kearns-Sayre syndrome, oculopharyngeal muscular dystrophy, myotubular myopathy. Now, other patterns. So humeroperoneal, so it's like proximal upper and distal lower. Emery-Dreyfus, facioscapulohumeral muscular dystrophy. Distal upper and proximal lower extremity weakness. We already talked about inclusion body myositis. Dropped head syndrome. So we were talking about the respiratory, right, involvement. So think about the drop head, again, central or axial involvement, ALS, myasthenia gravis, congenital myopathy, myotonic dystrophy type 1, isolated neck extensor myopathy, and myositis. So remember the differential in this case. You rarely come across, but ALS patients are pretty frequently you see drop head syndrome. But again, you check for the axial strength. Myasthenia gravis patients are weak, and that also gives you an idea about what? Axial strength. Give you an idea about respiratory. So that is a very key feature you have to see in these patients. Like myasthenia gravis, if the patient gonna deteriorate, like our patient we had, like move the patient to ICU or step down, we need to monitor the patient. So even on clinical assessment, FVC, FEV1 gonna happen later on. Focal weakness. So again, we talk about the pattern, but again, we say it's like monomilic or bimilic it could be, brachial or lumbosacral radiculopathies, entrapment and traumatic neuropathy. So, but it can initially could be because of vasculitic polyneuropathy or autoimmune, but most of the time that is rapidly progressive and diffuse. Combined upper motor neuron, lower motor neuron lesion. Again, there's a whole set of differential diagnosis. So I'm gonna go the way I kind of approach it, because it becomes so hard to go by individual disorders. So there could be genetic disorders, nutritional disorders, very common, like the one we had. B12, peripheral nerve disorder with the central involvement, right? So I just use that mnemonic vitamin, you must have heard of it. So vascular infection, inflammatory, trauma, toxin, autoimmune, metabolic, nutritional, genetic. I just added a few things according to my taste. Iatrogenic, idiopathic, neoplastic, paraneoplastic, social, which is like psychiatric or diagnostic workup. Okay, so there is general, there is a targeted diagnostic workup. So blood workup, neurophysiology, CSF analysis, imaging, and tissue biopsy. So again, general is kind of you just throw it out to kind of have some ground numbers, and then you kind of try to do more targeted workup. Again, general is also to make sure that patient is not having a systemic disorder. So this is general. CBC, ESR, CRP, RFTs, LFTs, electrolytes, urine analysis, urine toxicology. Targeted, TSH, usually TSH we do it, but I have never, I think maybe one patient where we suspected neuropathy because of gross hypothyroidism, but it's not common at all. But the most high yield investigation is hemoglobin A1C, random blood sugar level, or OGTT. CPK and aldolase for the muscles, B12, protein and immunofixation electrophoresis for neuropathy. Again, on the same line for B12, methylmalonic acid, and homocysteine level. I presented a little poster back in New York. Even with the normal B12 levels, your methylmalonic acid could be abnormal, and you have to treat it. Okay, have your metal screen and urine porphyrin levels. If your first line or tier 1 give you some problems or some clues, then you can do ANA with Reflex Anchor. There are a whole sort of antibodies that you can do for further assessment. Combined lesions, B12, copper, urine ceruloplasmin levels, and then vitamin E levels, and then zinc levels, very long chain fatty acids, HTLV, and HIV. That's what's the bread and butter of neuromuscular clinic. So nerve conduction study, repetitive stimulation, electromyography, single fiber EMG, QSART, which is quantitative pseudomotor axonal reflex testing. So electrophysiology is extension of history and examination. So even if you send a patient to electrophysiology lab for assessment, a neuromuscular doctor should do a brief exam and history before doing the electrophysiology. So remember, that's how important it is to do a history and examination. Now, coming to your question about the QSART and the autonomic, if you guys need it, depending on the time in future, you are keeping me busy, by the way. In 2 months, I have already done 2 lectures, right? And 1 for the symposium, so 3. So imaging, muscle MRI, ultrasound, these are all part of, like, I am not an advocate for a muscle MRI, okay, because that can give you, okay, your anterior compartment of the thigh is having more muscle atrophy compared to the posterior compartment. Similarly, for ultrasound is more of extension of the EMG rather than a primary investigation. Okay, but those are also developing more and more in future, so there is a role. MRI brain and spinal. Muscle biopsy, we rarely do, only for cases where there is an inflammatory problem, concern. Then we can do muscle biopsy, like all the antibodies are negative. Still, there could be necrotizing myositis. Similarly, for the nerve biopsy, so there could be non-systemic vasculitic neuropathy. And all the antibodies negative. Skin biopsy we do for autonomic testing. CSF analysis, we can do a total separate presentation on that. Thank you.